Welcome to BIScussions, the podcast where we will explore brain injury support, cognitive rehabilitation, and our mission to raise standards across our industry. I'm Natalie Mackenzie, Director, Founder, and Cognitive Rehabilitation Therapist at the BIS Services.
And I'm Eky, Operations and Registered Manager. Each week we're coming together to bring you expert advice, practical tips, and the real stories behind brain injury rehabilitation.
So whether you're a case manager, personal injury solicitor, support worker, rehab assistant, or a family member or client navigating this complex journey, this podcast was built for you. Hello and welcome to this week's episode of BIScussions. Today, Eky and I are finally joined by a very lovely guest, our first guest in a new studio. You may have noticed we've got a different background if you are watching. Today we have the very lovely Elizabeth joining us. Hello.
Hello. Nice to be here.
Elizabeth is not happy with me because I haven't given her any questions in advance.
No, zero preparation.
That's how we like it.
It's the way we like it. So, what we've decided to do with guests that come in, we're using the intranet to give us a little bit of a who is Elizabeth Nightingale.
Okay.
So I'm going to read out what the internet says you are and who you are. And then you can tell us.
Confirm or deny.
Confirm or deny. Okay, so it says who Elizabeth Nightingale is in a nutshell.
Ooh,
are you ready?
I'm intrigued.
So, founder of Nightingale NMT, we know that, and previous operations and neuroservices lead at Chiltern Music Therapy. Also in Therapy Provider of the Year 2025.
I was nominated. I didn't win, but
Finalist.
Chiltern won that.
Okay.
Chiltern won that, yeah.
Registered Neurologic Music Therapy Fellow, very posh, and qualified MATADOC assessor. Expert witness for medico-legal brain injury cases. One of the most experienced in the UK, it would have us say.
Okay.
UK representative on the Advisory Council for the Academy of Neurologic Music Therapy. First UK NMT therapist to be included as an ICAP.
ICAP.
Co-authored a chapter in the Handbook of Neurologic Music Therapy and has appeared on numerous conversations and podcasts. So you're basically a really big deal.
Numerous conversations, maybe conferences, but yeah, well, I don't know. I think it's also, we're such a small profession comparatively that I think, as you will know as well, being on the scene, particularly in rehab, it's a small world anyway, but even more so when your profession's quite niche. And I think there is still that opportunity if you're kind of quite active, people will sort of get to know your name a little bit. So there are kind of a handful of names that people might be more familiar with, particularly in kind of rehab, I would say.
I mean, you are another prolific conference goer. I mean, that's when we always see each other.
This is true. Basically, I'll sort of send you a WhatsApp and say, you going to this? And that will just seal the deal.
Of course.
Particularly if there's like post drinks. Then that really kind of
that's definitely, for anyone listening,
that's
the bar, absolutely, literally. So, how long have you been in music therapy?
So I qualified in 2013 and I did my master's at Queen Margaret University in Scotland, actually. So the first kind of 18 months or 2 years-ish after I was qualified, I was working up in Scotland. And then I relocated back down to England in 2015, and that's when I started working at Chiltern. So prior to that, I'd been sort of doing freelance work up in Scotland.
So that's when you got into brain injury and neuro?
Yes, so I did my neurologic music therapy training in 2015. So I joined Chiltern in the February, and then I think it was something like the September, I went to the Netherlands and did my NMT training. And then basically well, now post-COVID, we have these options to do some trainings online, and there's a lot more courses available. It's coming to Birmingham this July, but back then there tended to be there was a handful of kind of institutions that would host the training, and most of them were kind of more in Canada and the US. So that was kind of the closest option at the time.
Amazing.
Because it's kind of similar with Cog Rehab as well. There's very little in the UK, so obviously you've had to go elsewhere. Do you see it coming more over here?
Yeah, I mean, it's been encouraging. I think the last time I looked was probably around January, and there was less than kind of 200 UK affiliates with the academy. So there may have been more people who've done it, but whose accreditation has lapsed, who haven't kind of maintained their professional credits and designation. But, you know, that is comparatively a lot smaller than, say, Canada and the US. However, I think organisations like Chroma, Chiltern, I think have done a lot of work, and you know, a handful of others too, have done a lot of work over the last decade. And I think people are, particularly medico-legal, more familiar with neurologic music therapy as a particular area of specialism. And even kind of the broader creative arts therapies, I think there's a lot more open conversations and awareness and understanding of how that can contribute to kind of traditional rehab teams.
100%. I mean, certainly I've done this a long time, as you know. And the last probably 7-8 years has definitely been an uptick in just hearing it more about the need for it in a wide variety of cases. You know, when we're having MDT meetings, it's coming up a lot more frequently that we need to bring it in. So it is great to see. Just to kind of rewind a little bit, because we'll come on to you know, the medico-legal side of it and your expert witness. But for those who might not be familiar, what exactly is neurologic music therapy?
So neurologic music therapy is a system of techniques. So there are 20 standardised clinical techniques for speech and language, cognition, and kind of sensory motor and psychosocial function. So if I can remember this off the top of my head, so there are 3 sensory motor techniques. I think there are 9 cognitive techniques and 8 speech and language therapy techniques. And essentially we're harnessing how music impacts the brain to kind of train or retrain brain and behaviour functions. So we're harnessing kind of therapeutic mechanisms like rhythmic entrainment, like enhanced motivation, neural network connectivity, things like that. But the framework that underpins neurologic music therapy that's distinctive is something a lot of other allied health professions would ordinarily do, which we refer to as the transformational design model, which means we always begin with a functional assessment. Whereas in traditional music therapy, the music itself would form part of how we're assessing. Right. Whereas in neurologic music therapy, we always do a non-musical functional assessment to help us then set goals. And then the music is the actual treatment part where we're using a particular technique to address. So that's kind of maybe one part that's different. And we may personalize as much as we can aspects of an intervention that we're using around patient preferred music, around things that are culturally relevant, but they'll still follow a framework unique to what that specific technique is looking to target in the brain. So that's why they're more standardized, whereas music therapy can also address some of those functional areas, but it wouldn't be delivered in a way that is sort of standardized or has a particular technique attached to it, if that makes sense.
It does. Do you think that's fully understood in the sector, that distinction?
Well, I feel I've been banging a drum about it. So
I do, but you know, I thought I'd ask anyway.
I think it's not. I think, to be fair, I think because there's far more music therapists than there are neurologic music therapists. And I think it's always important to say, you know, I am a music therapist who's done additional training. And the closest analogy I can think of is you might have physio and then you might have a neurophysio. It's not to say that a music therapist who hasn't done NMT training doesn't have a good knowledge of how to support, but if that was an area they were really interested in, it would make sense that they would absorb kind of the latest research and understanding and how that might integrate into their practice. So it can be a bit of a signifier of kind of knowledge and additional training specialisms like you see paralleled in some other AHPs.
Interesting.
Did you always want to become a music therapist?
I did. Well, from about 16.
Wow.
So I know sometimes I'm sort of wondering when that, you know, whether I'm going to have a kind of a career crisis moment.
There's still time, Elizabeth.
Yeah, exactly. So when I was 16, there was a kind of residential performing arts centre for young adults with special needs down the road from me in Godstone, and it was called the Orpheus Centre. It's still going today, actually, and it was started by a guy called Richard Stilgo, who you may sort of remember that name from sort of 80s TV and media. And I volunteered there, and they did these kind of residential weeks for people that didn't live there. And they would come, and over a course of a week, whether you were interested in art and media, drama and acting, music or technology, everyone would work together, and then they'd put a performance on at the end of the week. And it was my first experience to seeing a real range of disabilities supported to engage in the arts in an accessible way to express themselves. And, you know, some people had designed the set, some people had written the music, some people were supported with AAC only. And that was my first introduction to this idea of seeing kind of the creative arts as a universal language. So my initial introduction to it really was, whilst they didn't have a music therapist specifically, that started me down this track of, oh wow, I wonder if there are jobs where you can look at supporting people to communicate, to express themselves through music. And that's when I learned more about music therapy. And then I volunteered there on and off for several years after that. And one of the main reasons I chose to go to Surrey, which is where I did my undergrad, is I thought their course was just very innovative compared to some of the other ones I was looking at. But they had a music therapy module.
Lovely.
Which was quite exciting. So I knew it wouldn't qualify me in anything, but it would be a good sort of introduction to kind of confirm if that's something I really wanted to do. But incidentally, over the years, I've met, I think, at least 5 music therapists who at some point worked or volunteered at the Orpheus Centre. So it's clearly like an inspiring place for people to kind of go down that
birthing centre for music
therapists.
That's
it. That's their strapline.
Yeah, I think that they
Once
can
you
have
go,
that.
Yeah,
love that.
But yeah, I don't know. I haven't really thought about doing anything else since then, apart from maybe case management in the future.
That was my other question. If you wasn't a music therapist, what would you be?
I could see myself evolving to that, I hope, because I think one of the unique things I think we bring, or that in my experiences, I've had that chance to work really closely with all the AHPs and often have calls and need to work jointly with everyone. Perhaps in a way, not everyone would necessarily, they'd work collaboratively, but they might not require kind of joint working for aspects of their work. Whereas for me to do my best, I really need that expertise, and my expertise is in how I then apply that using music. So I think it gives you quite a sort of 360 understanding of the different parts of the team. I also worked as a support worker when I was doing my master's, so I feel I've also got that experience of kind of being more on the client side, seeing what the rest of a week looks like and how that has shaped my understanding from sort of that perspective. And one of my colleagues that I used to work with at Chiltern, Kath Watkins, she's kind of a music therapist who's now gone into full-time case management at AKA. And to my knowledge, she's the first music therapist that's done it. But it's exciting to see other people ahead of you kind of follow that pathway, because, you know, traditionally, a lot of ATs, speechies, nurses, some physios, but who knows, maybe that will become, you know, a potential career pathway for music therapists in the future.
Amazing.
Absolutely. So what does like a case study or a general music therapy session look like?
Do music therapy on us.
What does
I want
a
to be
session look
I
like?
want to be a case study.
Take us through the process.
I'm a client and I'll come to you.
Okay, so I would begin with kind of my assessment. So again, depending on the diagnostics, that would inform obviously what kind of assessment I might do. If it's accessible to do a functional assessment, then we will do. Sometimes with our pediatric cases, we're often having to individualise those assessments, observational type assessments combined with kind of parent interviews and surveys to get that information, or working kind of closely with teachers. So different ways as best we can to get a sense of their cognitive profile, communication, movement, etc., depending on what the kind of reasons for referral are. And then that will inform helping us to kind of set some kind of clear goals, which then allows us to then identify what are the relevant techniques that would be appropriate for addressing those particular goals. And those might be cognitive techniques, speech techniques, sensory motor techniques, and we would design those specifically around what we're looking at. So let's say we were working with a child with global developmental delay that perhaps wanted to improve their receptive language. We might be looking at, okay, well, what are some core vocabulary words or some high frequency words that would be really helpful for them to be able to understand? And we might use a particular technique called developmental speech and language training through music, which may involve me creating a bespoke piece of music where I'm thinking about how can I be reinforcing meaning through how I structure the lyrics. How can I be using music to reinforce their understanding, drawing their auditory attention to aspects within the music? So that's a very kind of creative technique that I might use to make learning and understanding highly engaging, fun. Again, musical memories are laid down differently in the brain, so we're kind of supporting different kind of retrieval and learning processes. If I was also supporting that child, say, with increasing kind of range of motion in their upper limbs, we might use one of the sensory motor techniques where this is where I might do some close joint working with physio. What's a kind of safe range of motion? What's accessible for them at the moment? I might join a session and observe that. And then perhaps I would look at, can they perform that movement without me adding the music, and what is a sort of sustainable pace that they can do that to? And then I would strategically position instruments to imitate, let's say, a functional movement pattern, let's say reaching up to a shelf in their bedroom or raising their hand in the class or whatever it might be. And okay, how can I then imitate that pattern with instruments? So we're recruiting the same muscle systems, but we're now using things like rhythmic entrainment to help prime and cue the motor system. We're increasing that level of motivation. We're redirecting their attention less on this part of the movement, as in the moving, and they're actually trying to focus on getting to the top and then getting back down again. So their visual attention is also kind of directed differently. And lo and behold, we find increased endurance and repetition. And we know, obviously, for kind of optimizing physical outcomes, how key that is. So for the child, they might just feel like, oh, I'm having lots of fun playing these particular instruments, but there's a lot of clinical rationale and thought around how that particular intervention has been designed and what it's trying to do.
So much creativity, I love it. Do you actually, I didn't realise you actually made bespoke.
Oh, loads.
Can you share some?
Look at her face, look at how much her eyes lit up.
Well, I mean, there are certain populations, like, so DSLM, developmental speech and language training through music, that is a key example technique, which would involve a lot of individual composition potentially. And because I do quite a lot of work with pediatrics, I have ended up doing a lot of songwriting. And I remember actually when in one of my voluntary roles for the NMT Academy, when I met some of my fellow council members for the first time, I met one of the girls and she was like, I've seen some of your stuff, and I just thought to myself, she writes a lot of songs. And I was like, yeah, I suppose. But that's such a pleasure and a joy to me to spend time really thinking about how to support that child. Because if we think, say even say they were learning about animals, for example, you'd think about, oh, okay, old MacDonald, things like that. But actually, if you think about someone that has a learning difference or a brain injury, songs like that, they're not including kind of semantic information, E-I-E-I-O, none of the animals make that sound. It doesn't describe the colour, the size. There's no other information to help them make sense or context. So even something like that, how we might then think about, how can I use lyrics just as one element and make sure that I'm giving them all of the clear information to support their understanding? Then how might I use music, say dynamics, to draw their attention to a keyword, or maybe I make sure the keyword comes right at the end of the phrase. So it's drawing the ear, and then there's the keyword. And then if we're moving into me leaving a gap for them to fill that in, again, kind of anticipating where that word comes. So there's lots of kind of creativity when we're thinking about the composition side, but other techniques follow a very strict protocol, like melodic intonation therapy. There's still options to create the melody, but in that technique, that would be for clients, say, with expressive aphasia. And that follows kind of a 6-step process where what we're really looking to do is engage more of the right hemisphere and look at an alternative into the damage that's on the left language centre, and use sung phrases. So, you know, a phrase like, I was working with a gentleman this morning, and the phrase we were looking at, what time is it? So we're going through this process. I hum, then I sing it, then we sing it together, then we're going back and forth, and then I'm posing kind of functional questions. So if your wife had booked a restaurant and you wanted to know about when the reservation was, you might say, what time is it? So we've removed the music by that stage, but we're following that prosody when we're designing the melody. We're thinking about, how does that natural phrase sound? How can I exaggerate that in music to deliberately recruit the right hemisphere, which hasn't been affected by their stroke, and use that to help build a new pathway, and then remove the music, which is another key part of neurologic music therapy. Is we're looking where we can to remove the music, which again is slightly different than emphasis than in music therapy traditionally.
It's very similar to what we do in Cog Rehab. You know, it's implementing the scaffold, the strategy,
Exactly.
and then removing that at the relevant
That's
time.
phrased much better than what I said. So I
no, you did it beautifully. You did it much more creatively.
No, that's
You sang
yes,
with it.
exactly. Yeah.
I'm not singing. No one needs that.
No, that's music as the tool and the scaffold for the strategy, and then
Fascinating. So you work with children, but you work with all age groups, don't you?
Yeah, I predominantly work with adults at the moment, but I do have a small number of pediatric cases on my caseload at the moment, and I have worked with both throughout my career.
And what would be the usual reason for referring to you? Is it TBI, stroke, developmental, or is it quite varied?
So one of the things we do say in NMT is it's a function-based treatment. So yes, there is research for specific populations, but really what I'd be interested in is, what is the functional need? Now they may have, and it just so happens that I do a lot of work in neuro, but neurologic music therapy is not only and exclusively for people with a brain injury. It might even be, we might be supporting people who are neurodivergent. We might be supporting people just psychologically with music, psychosocial training and counselling. That's one of our techniques that we might use.
That's really interesting. I wasn't aware of that.
So it may be more common in our sector that the referrals that people are working with will be around that, and certainly that's true of myself, but really it's about referrals, not about loving or liking music, although that's great. I would always be going back and saying, okay, but what are the things that they're finding difficult, and what do I know about how music can support with that, and then selecting relevant sort of treatment techniques around that, if that makes sense.
It does. And how long would you generally be involved, or is that again kind of functionally dependent where they are in their recovery? Presumably you work alongside all the others, we do, members of the MDT. Is there any evidence about what is the kind of optimal input time?
That's a great question. Well, I mean, certainly the research advocates for early intervention, although often that isn't the case in our discipline. I'm sure we're not alone in that, but certainly even in case managed cases, we're often brought in when the team is already well in place, way past kind of acute and subacute rehab phases, etc., when they're maybe back home in the community. That's not to say there isn't some great things that we can do, but some of that will be identified at assessment in terms of what's the scope that we can support with. And sometimes what someone may have anticipated would be the initial ways we're working. The picture evolves, and actually, you know, as we know with brain injury, it's, you know, systemic in terms of how it affects the family, and there's so much work that we can end up doing with siblings, with families as well. So then the work takes on a different shape, where we might be supporting our client with specific functional goals, but then there's another relational piece we might be brought in to support with around the family, around sort of supporting shared accessible time, equipping family members with new skills of how to support accessible communication, or how we might be linking in with the other MDT members to support the creation of a multi-therapy program that's actually feels achievable because it's music based and fun for the family to all do together. So yes, we can work on our physio and OT goals, but they're going to be designed with support from myself perhaps, and I've done that sometimes, where integrating kind of multiple programs into maybe one music-based program.
And how do you track, I suppose, the progress being made?
So again, using kind of outcome measures, assessment, self-reported things with families as well. Obviously getting that direct feedback from families is really important, but certainly we would intermittently be looking at whether that's goal progress and the timeline in which we've set those. It might be that we're looking at reassessing. So part of that kind of transformational design model is we look at reassessment before we're looking at how is that generalizing into every day. So that would always kind of form part of how we're working, but the frequency with which we do that would very much depend on what the goal is. You know, so some standardized assessments, it might only be appropriate to be doing that annually, whereas others, if we're looking at smaller things, for example, even the gentleman I was seeing this morning, a small individualized check-in that I do every week is seeing if he can recall the phrases we've been working on with a prompt. So that is something I can track every week. It's not standardized, but it's giving me a sense of how is that carryover beginning to be implemented, and I can be looking at that over time to see, you know, how much reinforcement is he tending to need to learn a completely new phrase and then apply that in function.
Interesting. So you said, and similar to other therapies, you often come in a bit later down the line. Is that a funding issue? Is it an understanding of the need, or something else, or all of the above?
I think probably a mixture of all of the above. In my experience, I think that tends to be more around the particular understanding and awareness that a case manager may have about music therapy, or their own experience of perhaps just working with music therapy and maybe not working with neurologic music therapy. So maybe not being as aware of how we might support in some really kind of functional ways to rehab as well. So I think it's a mixture really, but I don't think funding is a huge barrier because, you know, comparatively, you know, we're not any different than any other member of the team, and
That's
actually we see a lot of high engagement.
Yeah,
you know,
and that's good to hear, because I think certainly we hear a lot about the slowness of the process is often down to the justification of need, and I think from my perspective as a, you know, obviously in the industry but outside of your niche, seeing that comes back to that awareness piece. There is more awareness of it now. It's spoken about more at conferences. You've done a lot of work around that, and, you know, banging your drum, as it were, with others. But I think it's good to see, because I mean, we still have issues with having to justify our input, and it's interesting to know and see if it's kind of the same kind of roadblocks that can happen. But I think, as you say, it comes down to the understanding of a case manager, but also how it's explained to the funder, whether that's an insurer or anybody else, exactly how it's put across.
Yeah, and I think we see this pattern in rehab. Like if we think about the history of rehab, or even think about, say, the role of an OT 30 years ago, and people's understanding of the scope or misunderstanding of the scope and how that has evolved. You know, so we see that over time, you know, disciplines get more understand. I mean, and I'm sure lots of OTs might be listening and saying, well, trust me, people still misunderstand, you know, but I think I do take encouragement from that any kind of any innovative change or addition to rehab, there'll be people who are on the pulse with that and want to take risks and try and explore and let's go for it, and other people that will kind of drag their heels a little bit and take longer to kind of get on board with things. And to be honest, that's also reflects my experience when I've been working with clinicians. I've worked with MDT members who are really doing cutting edge things, and it's really exciting. And I've had the chance to work with other people who perhaps work a bit more traditionally and maybe aren't as open to thinking about other ways of working. So I think that is reflective of clinicians as a whole.
No, I agree. And other therapies that are kind of similar, does things like drama therapy, art therapy kind of come, I might not be able to comment on that, but does it, that they kind of the similar sort of not misunderstanding, but you know what I mean?
Yeah, definitely. And like, you know, it would be out of my scope to kind of comment in detail about either of those. But I know one of the services I'm working at the moment, they have a drama therapist there. And actually it's been really interesting learning a little bit more about what she's been supporting with. And some of that has been around kind of role-playing challenging social situations, or thinking about going back into employment, role-playing interviews. And actually there's a lot more application. You know, it's not like they're sitting around a circle waving scarves, although that may be something. Similarly to people think music therapists just shaking a tambourine. And look, some of us will get in a group and we'll shake a tambourine sometimes.
I've seen you shake a tambourine.
Well,
I thought you were going to actually bring one today. I'm quite disappointed.
There's a tiny one in my handbag. No, I'm joking. But in the same way, it's not to say there aren't times where that part of the work may be there, but actually to make a judgment call about the whole scope, I think is misinformed. And, you know, I know Dan Thomas from Cromer has often sort of said this thing, or I've heard him say at conferences recently, which is kind of like, may I respectfully suggest that if you haven't thought about whether arts therapy can help, that may be an indication of kind of a gap in your understanding on your part. And maybe that's something to kind of reflect on and go away and find out a little bit more, rather than making an automatic assumption. But it's interesting. I mean, people will make automatic assumptions of my scope without asking me a single question about it. But
and that's why it's so great to have you on, because I think this is part of it. It's kind of that, to challenge those assumptions, because I think absolutely, and I've heard Dan say that as well. And I think my assumption would be that it's actually relevant in probably nearly every case. Certainly if we were to think about all of our clients, as you're saying, you know, if there's a gap there, it's probably likely that it should be considered. Is there a time when it's not clinically indicated?
I think if the client isn't medically stable, that's not appropriate. Yeah. Obviously that's kind of essential. I think depending on what the reasons for referral are, like, you know, depending on the region or the lesion of injury, certain techniques wouldn't necessarily be appropriate for addressing neurobehavioral issues, for example. So, but again, that would be the expertise of the NMT should know, based on the diagnostics, what is appropriate for me to be able to support with or not. And that's what, you know, they would be able to assess and identify. I mean, on the whole, I mean, people have asked me that question before. I haven't personally. I think I've only had like one instance where I've maybe recommended art therapy instead, and that was primarily because the way they were choosing to engage a tool in the session was more through other creative means. And I thought, okay, this isn't something they feel able to engage with for whatever reason at this time. But there's obviously a draw to a creative medium, and an art therapist may be better placed to work with that particular person. But, you know, I often say to people, I think sometimes, and maybe this is true of drama and art therapy, I don't know, but I feel the title music therapy is a help and a hindrance, because I think it generates a lot of assumptions.
I was just about to say, I think the myth is like music therapy, you have to be musical to be interested or to be referred. So I think that's been my myth, is that people who are referred have an interest.
Yeah, let's call for a rebrand. That's what I'm after.
But I think that is like, are there any myths that you want to clear up? Like, does that make sense? Let's give you the forum. Are there any myths that you're like, I would love just to clear that up? Like, just clear it up. People refer to music therapy do not need to be musical.
No, 100%. Okay. No, don't need to have any musical proficiency. They don't necessarily need to have any kind of particular passion for music, because that can be really helpful, sure, and most people do have some kind of autobiography when it comes to music. But that's obviously helpful when we're personalizing our interventions. But in terms of experience playing instruments, even irrelevant. Really, what we're looking at here is, how is music impacting your brain, and how can we harness that as a tool for your functional rehab? It just so happens that you'll probably enjoy it, which isn't a bad thing and can be really helpful.
You might like it.
Yeah. And again, I think to your point, Eky, about, clearing up myths, I think sometimes because to the outsider, it looks like someone's just having fun banging a drum or singing a song. Whereas I could go to town and explain my rationale of, okay, well, first we started with exercises targeting kind of breath control. And actually then we've been working closely in liaison with SLT around different mouth positions and working on oral motor skills. And now we've managed to graduate into looking at trying to trigger some automatic speech with some familiar songs. But someone might just think, oh, we're just singing some songs together. And actually, almost another hindrance is because it's so enjoyable, maybe sometimes people don't take it as seriously.
But certainly, like the clients that we have, really do look forward to their music
Absolutely.
therapy.
And I think that's important.
Which is really important.
And I actually think that maybe that's also the problem.
They enjoy it too much.
This is it. When you don't
awful.
And they need to not want to go to their session.
I generally, out of all the therapies, all the MDTs that I've sat in, music is probably one of the things that is probably the less pressurizing as well, because the approach is different, I think, personally.
Yeah, and I think it's an interesting point that you bring up, because so music therapy, so my primary foundational training, music therapy is an established psychological intervention. So the two most common routes in are an undergraduate in psychology or in music. So we do a lot. I mean, and yes, of course, there are different schools of music therapy. So you have like psychodynamic music therapy, music-centered music therapy, to name a couple. But in essence, in my training, I learned a lot about psychoanalytic theory, and that informs obviously how you form connection in relationships. And I think that is a really unique skill for a music therapist. It's not just using the music, but their ability to foster connection in relationships. And obviously, if you then have additional understanding of how brain injury can intersect with some of those challenges, I think that's a very unique and valuable asset to a team. So yeah,
I think also though, but I also think music therapy is one of those, it's a fun, and I think the people delivering it, there's maybe a myth, you'd correct me, you're just fun, loving going people.
Some people say I'm fun.
And you're always smiling.
Yeah. I don't think I've ever met a music therapist who looks dull and sad.
Well, do you know what I've thought before? I thought, particularly with my kids' work, because I had to take a lot of energy. I've thought I'd love to do some research where I track my heart rate, my calorie output, pre and post, like some of my kids' sessions, because they require a lot of energy, but also to engage,
absolutely,
to model, to demonstrate, to inspire. All of those things, I think, can take a lot of energy, but it also, music gives you a lot of energy too, and motivation. So it's kind of this kind of reciprocal.
It's that mood regulator. Like, we all turn to music for a reason, I believe. Like, I turn to music as a mood booster. So I think people coming to utilize music therapy, regardless of what they've come for us as in terms of neurological, but I just generally think it's a mood booster. So why would you not want to be happy?
Well, absolutely. And also, this is one of the things that I certainly feel passionate about, and I think is characteristic of most NMT therapists, is encouraging the team to think about different ways of integrating music into their sessions, within their scope, but there's still, a lot of generalizable ways of using music to support those sessions, to support that client to have optimized arousal for the session, to help alert them or to help them regulate. Just this week, actually, I was chatting with a psychologist at one of the settings I work at, and there's a gentleman who has been being supported with a range of strategies to support with his anxiety, and I've only just started working with him, so I was aware that there was a lot of breath-based work that he'd been doing, that had been introduced with SLT and psychology, that there'd been various other kind of strategies that the psychologist has been exploring. And, you know, one of the things I said and discussed with the client is looking at creating a particular playlist to support them specifically with that. And he was very highly motivated by the idea of working together on a little project to then put that together. And similarly, it may also feel more natural in a moment of anxiety to put on his playlist when he's out and about on discharge, perhaps rather than in a public space be doing his breathing, maybe. So it was just about having options. And, you know, I chatted with the psychologist and he was like, this is great, you know, as many different options for him to utilise and initiate as possible is great. So I think it's, you know, we're complementing in different ways, working towards the same thing.
I love that. And in other things like persistence disorders of consciousness and things like that, do you work in that sector too?
I do, yeah. So that's where I think you referenced at the top, like I'm MATADOC trained. So in the MATADOC, that stands for the Music Therapy Assessment Tool for Awareness in Disorders of Consciousness. So that essentially is a validated assessment tool that can support with both diagnostics, but goal setting and treatment planning for clients in PDOC. And one of the unique aspects of the MATADOC is it's highly sensitive in the auditory domain, which is really important because that's been shown to be the most preserved and most sensitive network for those that perhaps in a vegetative state or those who have limited kind of physical motor output. So it has a lot of value if we're looking at, yes, curating guidelines for music for leisure based on sensitive observations, or even curating what kind of music would be appropriate, but actually a lot of real practical applications as well. So, you know, if we observed that at assessment that the client consistently responded more to higher pitched sounds on their left-hand side, that would have implications of where to deliver auditory information when speaking to the client, and that may even give some guidance for carers to increase prosody, things that family often do naturally and say, oh, he's more responsive. And I think, well, I bet if I match that up with what I've noticed, it's because you're naturally saying, oh, hi, darling, good to see you. And actually, okay, that tracks with the fact I've seen they're more responsive to higher pitches. So maybe we can all think about raising our prosody when we're addressing them. So it's not just about, it's using the music and then how do we extrapolate the non-musical application of what that is. Yeah, exactly.
Interesting. So is it like we see on the TV when you play the favourite song of somebody that is in kind of a coma or disorders of consciousness? Is this what happens?
So there's an aspect in the MATADOC where you would use a familiar song from pre-injury, absolutely. So again, thinking about individualised responses, there are kind of a couple of main areas. So one is the familiar song, which is really allows us to look at kind of behavioural changes to salient stimuli that's going to be really meaningful for that individual. But we would also look right at the start of the session. The first way we're introducing any auditory stimuli is through kind of very graded intervention, where we would begin just first with playing a single note in line with their exhale and then their inhale. So we're automatically then getting auditory feedback. If their breathing's getting faster, slower, we can hear it because we're matching, right? So even if their eyes are closed, we're getting an auditory feedback that's telling us a bit about what's happening in terms of arousal. Then we layer that. So then we would move into, say, strumming chords. How much stimulation do I need to add before I see behavioural change? Then I would look at adding a change in timbre. So I would hum just over the top with maybe my guitar. Then really salient information, so just hello and their name. So hearing their name sung to them. So all of that graded exposure allows for really sensitive observation of at what point are they responding? Was I on the left? Was I on the right? Was I playing loud? Was I playing soft? Was it this level of stimulation or that level of stimulation? And all of that can then be extrapolated for kind of goal setting and guidelines.
Because we just have a client that's emerging through PDOC, and would the approaches be very different at the different levels, I suppose? Because obviously if he's emerging, it's so different. We're seeing a lot of different behaviour changes at the moment.
So, I mean, obviously, depending on what their classification would be, obviously that would, define what goals would be appropriate, also based on what we've seen. But, we would work with someone through that pathway as well, looking at how to kind of support them and use music appropriately to reinforce working on some of those goal areas.
Watch this space.
Okay.
Should we all have a song that is the song that is pulled out for if we were unfortunate enough to be in that situation? Do we all need a song in the background?
It's like a funeral song.
Yeah, and I love having funeral songs.
So
we have these random conversations in the office. I'm always like,
let's read funeral song though. I think
I'm always like very clear on you have your funeral list.
Yeah. Well, it's interesting you say that actually, because I had a chance to speak at the CMS UK conference in March, and I was talking about doing my talk was primarily focused on PDOC, and actually I did a little interactive thing where I'd shared a little bit about my background growing up, and Tina Turner was a bit of a staple growing up in our house.
Are you going to do a little demo for us?
I am not, but
and ladies and gentlemen, Proud Mary.
Yeah, I do a good Tina Turner impression, to be fair.
I don't doubt
if you get me drunk enough, I might do it for you. And one of the things I was sharing, probably to the horror of my parents, was, and there were a couple of key songs I have memories of. One was Simply the Best, blaring through the house. And the other, when we knew not to disturb them, was when Undercover Agent for the Blues was playing out of their bedroom, so we knew it was time to steer clear. Anyway, I then segued into asking people to think about a loved one initially, and think about what is a song that they love, or that is maybe the song you share together. And then I kind of moved on to thinking about, okay, in the instance that they ever had a severe traumatic brain injury, that song may just be key for helping reach and meet them. And actually, there have been some great initiatives over the years. Playlist for Life, obviously that's more focused around dementia specifically. But I think it's important. And actually, I've sometimes done this when I've been working in settings, is to say, on admission, could we also just capture some information about musical preferences as part of cultural understanding of that person? Not just about kind of any religious expression and cultural identity, but music, because that has implications for how the whole team can think about supporting or building rapport, connection, etc. Because that, that's always a part of my initial intake process, is learning a bit about that from families anyway. So I think,
what would be your song?
Yeah, I know, I was going to ask. Is it Tina?
It would be, wouldn't it?
I mean, there are a few songs that would, the reason that song is also really special to me is because not only do I have many memories of like dancing to the original, but when I had my daughter Olivia, I was introduced to an acoustic version of it. And it's kind of like slightly lullaby-esque. It's like acoustic guitar, it's slow down. And I used to sing it to her when I was, on maternity leave, or kind of those kind of late night feeds, and it would sort of play on loop on my phone. So I have all of these multi-layered memories now of growing up with it with my parents, dancing it, at weddings and at university with friends, or like post-night out parties in the kitchen, and then like with my daughter. So it's like, that's probably is a very special song.
I love that. What about you, Eky?
Yeah.
There's too many. I think there's too many. Like you, I think there's so many different layers. I think I'd have 2 or 3. I'm too on the spot. I wouldn't be able to choose.
And to be fair, that's helpful, because if you're working with someone long term, we wouldn't also advocate for just playing them that one song every time you saw them.
Yeah.
Obviously, for an assessment, that's helpful. But even in the MATADOC, we do 4 sessions. So there's room to look at different familiar music within that time.
I think that's a task for all the listeners.
Yeah.
I always say that, obviously in this line of work that we all do, we all need to have a file, as it were, if we were unfortunate enough to end up sustaining a brain injury, kind of who we'd want to work with us. I have my list. You might be on it.
Okay.
After today, you are definitely on my list.
I have my list, who I'd want as case manager, who I'd want as psychologist, and I think we need all to have our songs. By the way, mine would be anything by Elvis, in case anyone's wondering.
That's great to know, because I think people wouldn't necessarily make that assumption. You know, I've seen those memes, you know, when they're of like, oh, imagine our generation in care homes, like we're wanting to listen, like that some of the club anthems people would put slightly questionable lyrics, and you just sort of can't really imagine yourself at age 80 like singing along to that in the same way as like someone singing along to Elvis.
Yeah. No, I agree. Yeah.
You know, my love has got no money.
Yeah, it's not quite the same, is it?
It's not the same.
No, it's my little, the fact that not many people know.
It's a guilty pleasure.
I'm a big Elvis fan.
Oh, I love that.
Yeah. So it would be.
What's your favourite Elvis track?
If I Could Dream. If I Can Dream.
When you're ready.
No one
a
needs
duo.
that.
Take us away. That's how we're going to be closing the episode off today, actually.
Absolutely not. Nobody needs that. But we will. I wanted to just, before we finish, talk about your expert witness stuff, because you're the only one, right?
I'm not the only one, but there's a small number. Very small number. Although, interestingly, I've noticed a few more people getting accredited, which is really exciting, because I think, like anything, you need to have a few people that you could go to, but also I think it makes it more intriguing if it's not just one or two people that are doing it. So I welcome that. I think that's really exciting.
No, I thought it was brilliant when you did it, because, you know, I hadn't come across. Obviously, we work in a small niche sector, so as you say, it's absolutely brilliant, and I think it's important that more of that work is done. And I think it comes back to that, how you've explained, just it's not what you just see. There must be a huge amount that goes into the data collection, the evidence that you provide, the reports must be very, very detailed and extensive to show that functional change and kind of prediction of functional outcomes from that, which is a skill.
Yeah, and I also think, you know, at the moment, traditionally we're reliant on another expert having sufficient knowledge of our scope of expertise to make a recommendation for a treating music therapist. And as we kind of covered today, you know, again, that may be quite varied depending on their own experience. You know, so who's better placed to make a call on whether it may be needed, and if it is, what that would need to look like in terms of frequency, duration, etc., and what that could support with than a music therapist. So at the moment, I anticipate that would be more for kind of more complex cases, particularly where there's maybe more complex cognitive profile, or in PDOC, for example. But who knows how things may evolve over the next kind of 10, 15 years in that area. I'll be interested, but at the moment, I'm just happy to be learning and contributing.
And which you do very well.
Oh, thank you. Well,
final question on, obviously we work in a sector where funding isn't so much of an issue, but if anybody's listening that has a family member who has maybe been a stroke, or there's something that's occurred that means that they can't get kind of private, are there groups, is there kind of like a pathway of getting some sort of NMT that way?
It's a good question. Well, there are different providers in the UK, some of which offer subsidies, some of which offer access to kind of free therapy as well. So it'd be kind of doing your research, or it may be that if somebody went through our professional membership body, which is the British Association for Music Therapy, they may find a therapist there who could then support with some signposting around that. But it is probably an area that's not super joined up in terms of readily finding that. But some of the big providers like Chroma, like Chiltern, Northrop Robbins, etc., should be able to help signpost to that sort of support.
Yeah, because not everyone's got the
well,
same
no,
pathway,
exactly, absolutely, and there's a lot of freelancers as well that might offer kind of more affordable rates. I mean, one way I would say for NMT specifically that's helpful, that is a kind of easier go-to, is the Academy website, which is nmtacademy.co. It has a section where you can search the directory. So even if you just put in UK or even your area, you can find and then contact someone in that area. So that can be helpful for finding someone local who at least has training.
We'll pop those links into the information. I've learnt loads today.
Oh, I know.
I thought I knew what you did. I do know what you do, but I like the deeper details of it.
Oh, well, that's good to know. 'Cause, sometimes you feel like, I feel like I'm always beating that drum or saying similar things over and over. But it's good to know that.
Well, isn't it? You meant to say that people need to hear things 11 times for it actually to be
Is that
encoded.
what they say?
Yeah.
And maybe if they sang it once, it would just go in differently. That's it.
Maybe you
Can you
should
just end on a note?
La.
And if people don't know you yet, they probably do because you've been banging your drum. But how can case managers or anyone looking to bring you into the service contact you?
Well, you can reach me on LinkedIn, Elizabeth Nightingale, or through my website, which is nightingale.nmt.co.uk. I'm pleased to say I have a small team of associates now.
Amazing.
So we currently are accepting referrals in London, Surrey, Sussex and Birmingham. So we are a small but mighty team. So we're always happy to hear. And if we can't help, I'm fortunate to be quite well connected with NMTs in the UK, so I'm always very happy to signpost and make recommendations too.
Amazing. So yeah, please do get in touch. Okay, thank you so much.
Thank you so much.
You're welcome.
That was great. And join us next week for the next episode of BIScussions. Thank you.
Thank you for tuning into this episode of BIScussions. We hope you found it insightful and inspiring, and we continue to explore ways to raise the standard of brain injury and support and cognitive rehabilitation. If you have enjoyed today's episode, don't forget to subscribe to the podcast so you never miss an update. And if you know someone who might benefit from this conversation, feel free to share it with them. For more resources, insights and information about BIS Services, please visit our website www.thebis.co.uk. You can also connect with us on LinkedIn, Instagram and Facebook. Thanks once again.